Hey, everybody. Hello. Welcome back. Hello, Amy. How are you?
I'm okay. How are you today, Vincent?
I'm okay. I'm okay.
It's good. Plans for New
Everybody.
Year's Eve?
I don't have any plans. I'm going to edit podcasts.
Yes, you did a bolus of them this week. And you have what? Twim tomorrow?
I have Twim tomorrow. This is my third podcast of the day. I have Twim tomorrow and Twiv on Friday.
You're in
But
review.
everyone say hello to Amy. She's back.
I am back.
Okay. I hope not everyone wants to talk about certain variants.
Well, I don't really want to talk about the variants, but I also don't want to be corrected all of the time, like about things that are not incorrect, like having people write in saying cyber green works by fluorescence intensity. Fluorescence intensity is a direct proportion of concentration, local concentration. That's
Um,
what it is. So to
people are
write a
saying
comment,
people are saying
is
hello.
ridiculous.
People are saying hello to you.
That's very nice.
Someone said there's an echo. Is there an echo?
A small echo, I think, but I don't know.
It must not be terrible because
I'm not
they all
complaining.
love you. Look, they all love you. They're all saying hello to you. It's great.
I don't know. I don't see anything. Maybe
Don't you see
one
the
day I'll.
comments? You don't see the comments?
No. Oh,
I
there
have
they
it.
go.
I have it
Yeah, I
set up
see.
so you
I
can see
see.
them.
Then when I did that, now there's an echo.
Oh yeah, you're getting an echo.
A little bit. A little
Hmm.
bit.
No
But
echo.
I don't
Everybody
understand. We'll
said.
fix it. Yeah,
Everyone
there's
says.
now an echo. I think you're sending the sound back or now
No,
there's
no,
an echo.
no. They
Okay,
said
well,
it's
whatever.
perfect. They said it's
No, it's not
perfect.
perfect, but we'll fix it because I don't understand. Nobody sits here during the week, so it's weird. Whatever. It'll be fine.
Oh,
We can all
Ireland. Here
fix
we
it.
go.
Well,
Ireland.
you did want to know where everybody is listening, where
Yeah, I
everybody
do. I
lives.
do. I was supposed to get the map, and Amy is the bomb.
I
It's
am the
okay.
bomb.
I don't mind if you just say hello to Amy. It's okay. I
They see you twice a week. They see me for 30 minutes.
yeah, I understand. And no
So
echo.
where do you
Very
want to
good.
get this map? So where do you want to get this map?
Um, I don't know. Is it, some of the live streamers have it. I have to look into it, but I haven't had time this week, so I'll get to it. Seattle, huh? Akron, Ohio. Westchester County, New York. Boston.
I can read.
Oh, you're seeing them. I'm sorry.
Yeah, I see now. Okay,
Trinidad and Tobago. That's very cool.
it's
Very
good.
cool. Scotland, 1 a.m. All right. Thank you. Thank you very much. Sweden. So what should we take here first? Someone said, Amy, I was a lab rat 40 plus years ago.
Yeah, they sound like my mom. That's what she says.
Amy's freshly immunized, or vaccinated, I should say.
Yes, I'm freshly vaccinated.
How's your
My
arm? Do you still have sore arm?
Yes. Both Ian and I complained today about the soreness of our arm. I think that's also why Ian wanted to chat for so long, is because, he wanted to know if I was experienced. Then I'm told not to take any aspirin, don't take any inflammatories, it'll dampen the immune response. I was like, I can barely lift my arm. I can't hold the thing, the bottle of the aspirin. It's fine.
Well, I think if you're curious about why Amy has, all right, I'll turn up my audio. That's easy. I sound down here. Are you tired? I'm a little tired. I can't sleep, and the reason I can't sleep is because people are attacking me for my views about the variants, and they attack me by email and on social media and so forth. So I'm a
Gotta
little
grow a
bit.
thicker skin if you're going to do this.
I have to grow a thicker skin. Yeah, that's the problem. Yeah, congratulations. So Amy's vaccinated because she works with SARS-CoV-2. Amy, are you going to check your seroconversion?
Eventually, yeah. Probably after I don't know, probably closer to March. So I think the second dose is the 19th of January. And then,
Mm-hmm.
you know,
Okay.
Probably, the end of February, beginning of March.
All right.
So, but
Yeah, I should ignore people, I know. But here,
yeah.
WHO says Nsaids and acetaminophen are fine after the vaccine, but not during or before. What do you mean after? How long after?
Whatever.
Because
They'll
the
be
arm
fine.
pain only lasts a day or two. Profit
Yeah,
is
speak
always
for
a tax.
yourself. Because the last time we got vaccinated, my arm hurt for a week when we got the flu vaccine.
Well, I'm not a prophet, but I just have views about how how data should be produced and interpreted,
Analyzed.
analyzed. So that's, and I still stick to my views. But the epidemiologists are convinced that these variants are more transmissible, and I am not. So we'll see. We're going to see what happens because they have spread to many other countries, and we're going to see if they explode in outbreaks or if something was just weird in the UK. All right, here you go. Amy, you gave a great explanation of how PCR works in a previous Q&A. One of the arguments for the variant being more transmissible is a reduction in CT for the N assays, just more sgRNA.
Probably.
Possibly that's one. Yeah, that's possible.
Well, it's actually, you can't say anything because it's a single time point. So so you need actually 2 time points to determine if you're actually at the increased time when you're newly infected and your virus load is going up, or you're past the peak of infection and your virus load is going down. So if you take a random sampling of people, you have a percentage of people who are going to have very high CTs or very low CTs to reflect very high viral load. Right? And you have and more people get tested, that probability goes up. So of course you're going to see more and more people that you say have higher viral loads, and then you do some, it makes sense. That's how it works.
Thanks everyone for your support. I appreciate it. Any more news on long-term issues after contracting SARS-CoV-2? So Amy and I had cookies with Ian Lipkin yesterday, right?
Yes. Cookies and tea, 3:00. I feel like I'm the Queen of England. I'm having high tea.
And he is very interested in long-term COVID and is working on trying to figure out what's going on and eventually develop some therapies, right? Would you say that's correct, Amy?
Yes, but he's very interested because his colleague has long-term COVID. The guy's a disaster. Ian's very worried about him.
We stated last week the South African variant died. That was wrong. It hasn't. It's still circulating. Our apologies for misstating. There is a preprint on medRxiv now that describes the variant and its emergence pattern, which is very good. So just search for that. And I'm sorry, in a live stream, sometimes we don't have all the facts at our fingertips. So we'll try to do our best. Yes, we said earlier, do nothing different for the virus. Mask, distance, wash hands. Yeah, I agree. I think if you have a more transmissible variant, if you do, right? So the evidence is suggesting it, but not confirming it. If you do, what do? The same things we're always supposed to be doing, right, Amy? Masking, distances. Look, Amy is alone in the lab. There's nobody else there. Of course.
I'm alone. I was going to say, this is not the example you want to use because I'm alone whether or not there's a pandemic or not. But yeah, you should be more virulent or vigilant about, social distancing, right? I mean, that's really all you can do, and then hope that they can produce more vaccines. They can get, production, to increase tremendously.
I don't think swabbing is a homogeneous sample to determine viral load. Yeah, swabbing is difficult because you don't get the same amount of sample from each patient, but you have to have a way of normalizing it if you want to do infectivity assays, which I think should be done. And you could do that, right? Couldn't you normalize to adjust for the volume, Amy?
Yeah, you can normalize. You use beta-actin or some housekeeping gene. And by the next-gen sequencing that they're doing, they should be able to normalize that. But it's not just the swabbing. Like, it's the whole process. You lose stuff. So it's, swabbing, it's extraction, it's the whole process. And deciding where you're taking the sample. Are you just going at the bottom, the front end of the nares? Are you going all the way up and piercing your brain? Or are you taking the back of your throat, like in a nasal pharyngeal swab? So it depends on what you're doing.
So someone, here we go. With past vaccines, it took 10 to 15 years before FDA approval. What percent of those were in human trials? Well, there's a lot of phase 1, 2, and 3 takes many years, but the data analysis, I don't know what the percentage is, frankly, because a phase 3 can go on for 2 years, and then it could take another 2 years to analyze the data. So it's
phase 3 has to minimally go on for 2 years.
Three, I meant to say, yeah.
Well, these are geared for 2 years. All of them are geared for the last sample to occur 2 years in 2023 or whatever, whenever,
If herd immunity threshold is calculated with R value, would you need a higher percent of people vaccinated somewhere like New York City where the population density is higher? It's a really good question that we...
It is a good question, but it's not... It doesn't account for the fact that New York City, by having such a high population density, that when it went through the first wave of the pandemic, a large amount of the population seroconverted.
Mm-hmm.
So if you're seropositive and you don't, let's just assume everybody who's seroconverted also developed neutralizing antibodies, then you would not need to you would probably not need as high a percentage of the population to be vaccinated, right? They would have natural immunity. So exactly. This is an interesting question, but there are other things that you need to factor in. You can't just go by the R value.
So if you go by R value, which was determined early in China, it's 2 to 3, which would be 50 to 70%. But, if you listen to Dr. Fauci, he's been raising his percentage for herd immunity now. He's up to what, 90%, Amy?
Yeah, 80% actually, 80 or 90, somewhere around now. Yes.
So, yeah,
and then somebody complained that I said that after 80%, you could get rid of your masks. 80% of the population being vaccinated, you could get rid of their masks. And somebody complained and was like, "Oh, there's no math. She doesn't know what she's talking about. Can't believe Vincent didn't correct her." And it's like, that's exactly what Fauci's saying. That's the whole point. If once you hit that golden number of herd immunity, that's when you can get rid of you can safely say, I don't need to wear a mask anymore. I mean, that's the point.
How and why would any virus be more transmissible? Well, there are many ways.
Well, that's the goal of the virus.
Well, it's not a goal, Amy. Viruses don't have goals.
Well, no, but but that's what viruses do, is that they become more transmissible and they lose pathogenicity along the way. And it's the adaptation process. It's the consequence of the adaptation process to a new host, to a human host, or to a dog host, if we were talking about a dog virus. That's the consequence.
So when a virus first enters the human population, if it's not well transmissible, it's going to become extinguished. It won't spread to enough hosts. So one of the ideas is that early in a spillover, the mutations are fixed that improve transmission. Now, here we are a year into it. You can ask, well, why? What's the reason for increased transmission? It could be random. It could just be a mutation that is introduced and randomly increases mutation. So it doesn't have to be selected for, actually. My problem is that, I don't know.
You have a lot of issues.
I have a lot of issues. Well, there are mutations, D614G, then we have the UK variant, the South African variant. And it could be that each population is different and different mutations are doing different things. So we'll see. I want to see in the next few weeks, we're going to know what's going on.
Well, the thing is that there's common mutations. They're all on the
common, yeah.
Right.
Yeah.
But they're all on the D614G backbone.
That's right.
And they all seem to have the 501Y and the 484K or something or other. So there was obviously there's commonalities.
Maybe
Right?
do they
So
all
you
have
can't really
Orphate?
say.
Do they have?
No, I don't know. They haven't all been characterized for Orphate deletion.
Okay.
But the end is you're not just opposed to the idea of that they're more transmissible. You're also opposed to the interpretation of that being that they're going to be more pathogenic.
Yeah,
Or
so
more
far
or
so far it doesn't seem that they're causing more disease.
well, I
but the
believe
numbers-
that the health minister of South Africa wrote a letter that I text you that says that there is no correlation and that and then the Japanese health administrator came out and said, yeah, this is what viruses do. They adapt to the new host. They become more transmissible during that adaptation process and they lose pathogenicity. And he expects that, in 4 to 5 years, this won't be a problem, but it will always be a circulating virus in the background.
Well, we'll see. We'll see. Look, this is a point that Daniel brought up the other day. In the UK, people are not being very good about what they're doing. So that may be underlying some of the issues that are going on there with increased transmission. That's something you need to deal with. So now we know the virus is in Colorado. We're going to see what happens to it there over the next few weeks, and that'll really be a telling issue there.
So let me get this straight. When I come out and I say, it's because they're not really social distancing. You go to the house, you have a holiday party, blah, blah, blah. That's discarded. But when Daniel comes out and says, they're going to the pubs and they go to the grocery store and they say, oh, I haven't seen you in for so long. Now that's an acceptable thing. It's
No,
basically
I always
the
listen
exact
to
same
you,
thing that I
Amy.
said.
Yeah, I always listen to you. No worries. Hey, do you want to answer this? Bill wants to know what you find interesting at the moment. Just
About
for a
what?
break. Anything. Whatever you find interesting.
What do I find interesting at the moment?
Outside of science, or it could be science too, I guess, right?
Well, I thought the Jupiter and Saturn alignment earlier last week was interesting, right?
Yeah, that was pretty cool. Did you see it? I guess in New York you couldn't
No,
see it
you
very
can't
well.
see anything. But my friend and his partner and his partner's mother who wanted a telescope for Christmas, they're all into this and stuff. So that's kind of cool. I don't know. I'm interested in lots of things, right? I'm interested in art and music and stuff. And Pierre Cardin just died. I'm interested in how he was a, forefront thinker. In the 60s, he really modernized some fashion along with Yves Saint Laurent. So lots of different things.
Help me understand how patients immunocompromised or immunosuppressed for any reason are able to build a good immune response to the vaccine.
Well, I think it depends on what their immunocompromised or immunosuppressive mechanism is. Not everybody is the same.
Yeah. If you have an issue making antibodies, you're going to have a problem, right? Because that's a major part of immunization.
Right, but if you are an IRF7 variant and you don't respond well to flu, I'm not sure that that's going to be a problem for antibody production. You might not be as efficient, but you probably will get there. Not really sure.
How is vaccinating going in the U.S.? I think I saw an interesting statistic. It's going to take, at this rate, it's going to take us 10 years.
No, it's going to take 52 years.
I shouldn't laugh, but, in 1947, they immunized 6 million people in New York in 2 weeks. So I don't understand why we can't. Amy, is it a shortage of vaccine or is it logistics or both?
It's logistics right now. So Daniel said on Friday how there were 10 million vaccine doses sent out and only 1 million had been put in arms. So it's clearly a logistics thing. So when I said something about vaccination, years ago, but whatever. But we could just have a national vaccine day like Brazil did for polio.
Yes.
How Sabin had those big national vaccine days?
Yeah, but we don't have enough vaccine to do that, right?
Well, eventually they should be able to figure out how to manufacture it. But even still, you have these doses that are sitting in somebody's storage area at some hospital. I mean, if there are 10 million doses out there and only 1 million have been put into your arm, where are the other 9 million?
Yeah. I agree. Scientists in the UK on a select committee have said variant is probably very prevalent in other countries, but the UK has good genomic surveillance. That's true. They do have very good genomic surveillance. If you notice, the person in Colorado who has this variant never went to the UK, so it's clearly been in the US. For how long, we'll see as we do more surveillance. Yeah, absolutely. And that's why I said last week it's silly to impose travel restrictions because the viruses are already everywhere. There is a very good website that Nels showed me, Amy, which is being made by a graduate student of Eddie Holmes, and she's tracking all the variant-like sequences that are deposited in different countries every day. And so you can see right now it's in about a dozen countries. The most isolates are, of course, in the UK, and Portugal has 20 so far. And we'll see what happens. We'll see what happens.
I would have thought that South Africa would
That's
have had
different.
deposited.
Well, they have a different variant. Is it?
Yeah,
She's
but it's
tracking
very
both.
similar. It's
No,
very similar.
It's clearly a different origin, and it has. She's tracking those as well on that website. Let's see. Maybe I can find it very quickly here so I can give it to you because I think this is a good thing to have. So Tweevo 63, which we just recorded. Here we go. It's a very interesting global reporting. This is great. Global reporting. Global report investigating novel coronavirus haplotypes. The letters stand for Grinch. Here's the. Where
Dr. Seuss would love it.
Should I put it in the comments? Yeah, there you go. I just pasted it in the comments. There's the report. It's very cool. All right, here you go. This is Daniel's article in the New York Times, Amy. What do you think about CT values in patients to stratify risk?
Not if you only have one time point.
I don't see the data for this, frankly. Here, let me put up this picture to show you guys. Yeah, Daniel.
I don't need a picture. The picture is unhelpful. The
Well,
reality
it's not for you.
of it
It's for the
but
people.
the reality of it is you need to have at least 2 time points. Some mathematician corrected and said he would like 3. I'm always more advocating more data, but you need a minimum of 2 time points to decide, are you going up, are you going down, or are you staying the same?
Anyway, I don't see the data for this use of CT in stratifying. Okay, you have to get the data, and it was a New York Times article, so we didn't have any data. And I will ask Daniel tomorrow on TWIV for sure.
Well, I think that there's some. I think if you read further down in that, there's anecdotal data that says like if you had a CT value of like less than 20, 40% of them died or something, or went to the hospital or something or other. Whereas if you were 29 or over, you basically recovered.
All right, but I don't.
I mean, you have to whatever. The reality of it is it's not crystal clear.
Here's why I don't buy it. This is Daniel's COVID course. All right, so you have your exposure, incubation period. The purple is virus, is RNA load by PCR, and it peaks.
So what's your complaint?
And
so what's your complaint?
Can I finish? Let me finish. So then you have declining titers after this first week, and that those people can either recover and they're finished, or they go on to the inflammatory phase, in which case RNA levels continue to decline. So how can this be a prognosticator for whether you go into the inflammatory phase? Are you telling me that you're at different points along this curve and that predicts it? I just don't get it. So that's what I'm saying here. I'm going to ask him.
I don't think that I don't think your argument. I don't get it. I don't get the obsession with this figure, because that's not necessarily what they're saying. But whatever. Ask Daniel.
They're saying a certain CT early on is a prognosticator of progression to serious disease. I don't see the data for that, and I don't know how it would work if 80% of the cases go through that first phase and recover, and everyone has the same early phase. With high levels of virus in the nasopharynx, that's how it's transmitted. So how is that going to distinguish? But I will ask him tomorrow. Was the Pfizer or Moderna vaccine tested on COPD patients? I don't think it was. Do you know, Amy?
I thought that they only used healthy patients.
They
Or
had
maybe
some,
they used used mostly healthy patients, and then they had some of the comorbidities like diabetics and being obese and with heart conditions. But I don't remember CPOD patients being
yeah,
listed.
I did look at the charts, and you can go to some of the recent TWIVs, and we've linked to the Pfizer and Moderna documents that were submitted to the FDA, or you can go to the FDA website, and they give a list of all the conditions and all the patients who were used.
Here's someone who was your student and now is a third-year medical student in Northwestern.
Cool. All right, Wong wants to know, when they say variant, can you explain what that means? So a variant is a virus isolated from a patient that has some sequences in the genome that are different, some mutations that are different from the other. I mean, that's a variant. So
Well, you have a standard, you have a consensus sequence, and then you say this is this isolate has a change at position 472,000. Therefore, it's a new variant.
yeah, yeah. What do you think about the sensitivity, specificity, false positive rate of the home antigen tests about to hit the stores? I don't know anything about them. I know Daniel talked about one from Elum last week. I don't know.
Yeah, it's the $30 one.
Yeah, you can go on the FDA site, and they list all of them in their sensitivities and specificities. You know, the antigen tests are not going to be as sensitive as PCR, but you can, in theory, they're supposed to be cheaper, so you can do them more often, right? And that is supposed to overcome the lower sensitivity, right, Amy?
Sure, at free testing here in New York City, PCR or a lamp.
Do you
It's
have
free
free lamp
testing.
in
Yeah.
Really?
Yeah. You see ads on TV or on the bus all the time. Okay, so I have free testing. I could go as frequently as I want. $30 home antigen test. 10%, it picks up 10% of the cases, right? I think that's what they said, right? It's 10% sensitivity. Okay. Sounds good.
So here they had a COVID test where they swabbed your external nares, but asked you to blow your nose first. Exactly, that's what they do here, right, Amy?
Yes.
Blow your nose. Why do they have to blow your nose first, Amy? Amy and I have a little backstory here.
I have no idea why they make you blow your nose.
Well, I mean,
I think it's basically to like get rid of any debris and stuff.
Or plasmid that you might have in your nose.
Oh yeah. I went snorting right before I went to have my test. Although they seem to be very efficient at finding my test 6 weeks later.
Have you had any test results yet? 6 weeks?
Well,
oh my gosh.
Yeah, I remember the first one I went, they said they couldn't process, and that was like 5 days afterwards. So they told me to go back again. So I didn't go. I went Monday after Thanksgiving, and they have no record of this. It's now 7.5 weeks later. I'm not going until they have a new testing policy starting in January. I feel no need to do this anytime soon.
Yeah, I think you just want to clear your nasal passages and get a clean sample.
Yeah.
All right.
I mean,
Amy.
Chris wanted me to wash my hair and everything.
What's a founder effect? Do you want me to answer, or do you want to answer it, Amy?
No, that's for you.
Founder effect.
You are the author.
Here's the founder effect. When a virus goes into a person, let's say, and it has a certain set of genome changes, it's a variant of some kind, and then that person will spread it to others and others and others, and those changes are still present, and that's because it was in the first person, it was in the founder, and now it gets passed on everyone else who is infected in that chain of transmission. So the mutation is neutral. It doesn't give an advantage to the virus. If it were negative, the virus probably wouldn't transmit so well. And so it just continues along because it was there in the first person to be infected. And that can explain why a particular change, which randomly arises in the genome, can stay in a chain of transmissions for a while.
Well, I don't think you can just say it's neutral. I think it has two possibilities. It's neutral, or it can be neutral, or it can be or it can be beneficial.
Yeah, but then it's
complicated. But to ignore
the fact that pure founder shouldn't have any selective advantage. pure
No,
founder is just moving
no,
along with the flow of the water.
no. It can
Yeah,
always
it
have
is.
okay, well, it's wrong.
All right. Well, we can look it up. All right. How could the Oxford vaccine team screw up the trial with half dose? It wasn't the team. It was the contract manufacturers who were packaging the vials for them. They messed it up, because this is a complicated thing. You have to manufacture it and package it. And the company who was packaging it, who was a contractor, it wasn't the actual, AstraZeneca. They screwed it up. But it looks like the vaccine is being licensed in the UK, not licensed, but EUA in the UK at full dose, because that's where they had most of the phase 3 data for. And that's a problem because I think the efficacy was in the 60s, right, Amy? 60-some percentile for the AstraZeneca full dose phase 3?
Yeah, I think so, but I think it's better than nothing.
Oh, yeah,
I
I
don't
agree.
have a problem with it. I don't have a problem with it at all. Because you can't manufacture enough of the Pfizer and the Moderna. And there was a huge article in the Times or in the Journal about, the economics of the distribution, how like the poorer countries were being left out, and Africa is in a disaster zone, especially sub-Saharan Africa. So I have no problem with a third vaccine, even if it's not the best vaccine. It's something.
Yep, I agree with you.
So I don't see it as a problem.
Here's one for Amy. What's the role of Orphate in SARS-CoV-2? Some seem to discuss a role in immune suppression and evasion.
It's not clear what the role of Orphate is. So those experiments were generally done by producing Orphate in the absence of virus infection. And it was shown that it prohibits MHC class 1 processing and it's on the surface of the cell. And so it sounds like it could be a way to prevent immune evasion if you had a deletion of Orphate. However, those experiments are very hard to do because you actually need full-length virus and you need to have an animal to monitor the immune system. You're not going to ascertain its nuance by looking at tissue culture cells. And so Linfa has a paper that says, it really doesn't do anything because here in my tissue culture cells, it really didn't seem to have any effect. Well, there's no adaptive immune system in your tissue culture cells. So it's a little hard to understand how you came to that conclusion, but hey, he's the Batman, so whatever.
All right, someone had COVID in March, took an antigen test 2 weeks ago, was negative. This week he took it again, it was positive, and antibody test positive for IgG. What could this mean? It means the first antigen test was wrong, and the IgG means you're well after the original infection, so there's no more IgM.
Yeah, I think he's fine. I think I'm not concerned. He should be protected. Not concerned. Lots of tests go wrong all the time. My experiments go wrong all the time. Somebody today did a whole entire PCR and forgot to add template.
Happens.
Exactly.
Is it true that during SARS-1 funding was asked for broad-spectrum vaccine research and it was rejected?
Funding for who? Well, I don't understand the question really, but yes.
A number of investigators tried to get broad-spectrum antivirals or antivirals against SARS-1 and vaccines. But you could never get, after SARS-1 ended, you couldn't get any of that, certainly not from NIH. And as we've said before, companies...
has nothing to do with companies. It falls on the study section's shoulders.
Why doesn't it have anything to do with companies? You think companies want to make antivirals for a virus that doesn't exist anymore?
I don't think you should... I don't think you need to highlight companies. Companies are like a minutia of basic science research.
No, I think they're not. As you know, now they're making antivirals for this virus, and if they had done it earlier...
No, you can't say that.
Yes, I can.
You have a bias against companies, but it falls solely on the study section's shoulders. And if I were a member of those study sections, in retrospect, I'd feel really guilty as all hell.
Yeah, well, I agree on the study sections, but the companies are at fault also.
Yeah, like 3%. 97% of it comes
50%.
No, way too high. Way 50%. Too high. Way too high.
No, it's my number.
Well, your number's wrong.
That's why they like you, Amy.
Well,
I don't know where you can get a number from, Amy. You can't get 3% because companies make drugs. And if there's no virus, they're not making drugs.
Most companies contract out basic science. That's what they do. Most companies contract out the basic science and only get involved when you have a drug that is at a certain level ready to go into the clinic or to go into trials. Yeah. But most of it is contracted out. And most of this stuff comes from basic scientists who are curious and want to understand mechanism and develop these things to tease out a mechanism of how processes occur. And so the study section, like for somebody who works on spike, their response was not important, not interesting. We're never going to see SARS again. We don't need to understand the interaction between spike and its receptor. A 5. You add that all up, not fundable, not scored, not discussed. Go home and drink.
Amy, do non-pharmaceutical interventions exert selective pressure on a virus? So if you wear a mask, is that selecting for viruses that are more transmissible?
I don't see how, but I could be wrong.
Yeah,
most likely I will be told I am wrong.
Yeah, I don't think that these physical interactions are doing that because the virus has plenty of hosts to infect nevertheless, and therefore there's no pressure.
I don't know what the pressure would be, but whatever.
To find a new
because the reality of it is that the virus can go through the mask. The droplet that the virus lives in cannot.
Right. Yeah, to have some selection, you'd have to have viruses that squeak through, and as Amy said, it's the droplet that's being held back, so that doesn't make any sense. Ben says the UK is saying by February, March, things should be looking lots better.
I think it's a little early.
Where? In the UK? So apparently
I think it doesn't matter. I think it's still early because you'll still all be inside. I don't think you'll start to see any relief until you are able to go outside, like the middle of April.
Yeah, the UK now has 2 vaccines which they say can cover the whole population of England, which is Pfizer and the AstraZeneca. So maybe that's why they're saying that.
I thought that.
Go ahead.
I thought I heard or read somewhere, or maybe Daniel said it, or Mina said it, or somebody. I thought that I heard that the way that they're vaccinating, by the time that they finished the first round of vaccine for the vaccinating their entire population, they would have had to start revaccinating. That doesn't sound like they have it covered.
If you had a bad reaction to flu vaccine, what about COVID vaccines? Well, Daniel says if anyone has had any previous reaction to any vaccine, you need to speak to your physician and see whether it's advisable to take it, because it depends on the reaction, I suppose.
I don't know. I don't like to give medical advice. I don't want the responsibility.
No, I'm not. I'm telling what Daniel said.
Yeah.
Can you explain why QPCR is not as good as a quantitative measurement for viral shedding, and how infectivity assays can be quantitative? Seems like there'd be a lot of variability just from nose swabbing. Yeah. Well, infectivity is the ultimate, right? PCR simply does not measure infectivity. It measures pieces of nucleic acid. So infectivity, as Amy will tell you, who does a plaque assay every day, multiple times a day, it can measure all the infectious virus in a sample. But yes, variability, we were talking about that earlier. You have to have a way of normalizing.
Mm-hmm. Yes.
We should have John Campbell on. I'd be happy to have John Campbell on.
Oh, he's the nurse person from the UK, is that it?
Yeah. I'd be happy to have him on. I'm interested in contrary views, but what I'm not interested in is people telling me I'm wrong without saying why. If variant A has been infecting people in area X longer than B, yet variant B becomes dominant in 2 months, how can this happen if B isn't more transmissible? Because it's not just transmissibility that would control that. It would be behavior in people, for example. And what's key is to know the secondary infection rate, and that hasn't been done yet for this variant.
I thought that they had done some secondary rates. I thought that the document that you sent yesterday from the other the group in whatever the nerd group in I got the I got the acronym wrong. I thought that they had a whole paragraph that said that there was no difference.
No difference in hospitalization, but there's a slight difference in secondary infections. But Nels agreed that there aren't enough samples yet. Oh. What about vaccinating people that have already had COVID? Well, they are vaccinating people, and Amy knew someone yesterday who was vaccinated who had COVID, so there's not a concern for. So the issue here is that, I don't know, an enhanced immune reaction. If you're thinking of, say, antibody-dependent enhancement, you have neutralizing antibodies that are being produced. And the problem arises when you have non-neutralizing antibodies produced. And with the spike, with the mRNA, most of them are neutralizing.
Yeah, I mean, he spun it today to get the other person who's been sick with COVID, COVID to go get vaccinated as it was an immune boost. The kid didn't listen, but that's the spin that he put on it, is that it was an immune boost, which is fine. I think it's good.
All right, here's one from Lauren, who's running the Microbe TV Instagram page.
Oh, that's cool.
Microbe.tv on Instagram. Thanks, Lauren. Do you think the bandwagon publications, in fact, has done more good or bad, like the ACE2 paper from TWIV 690, and Amy was on that episode?
That's the bioinformatic paper?
Yes. Look at
ooh. Yeah.
Yeah, I think
that's not so happy about that.
You should hear us on a daily basis. Amy and I discuss the effects of bandwagon publications during these outbreaks.
So the bioinformatic and then the RT paper?
Yeah, that's another one. Yeah.
Oh, yes. This is good. Yeah. Love it. Keep going.
So I think, it's a big problem, but it happens every outbreak. There's all these bandwagon. People jump on it. Zika, Ebola. Amy can tell you Zika stories. It's just a mess, but what can you do? People want to jump onto the latest important thing.
No, they just want the money. They think that they're going to get this money. And having been a virologist, written a grant, and then getting a fundable score, what we considered a fundable score, and having the NIH come back and say to us, "We'll get back to you at some uncertain date." Not so happy.
Has a virus recognized that it's entered a new host? Well, the viruses don't do that. They don't recognize. They just get in. If they happen to attach to a cell and enter the cell and the cell is permissive, they will reproduce. If it's high enough titers, it might spread in the animal. If it's high enough titers shed, it will spread to something else. It's all pretty much random. And it happens all the time. Viruses enter the wrong hosts all the time. When you eat coleslaw, you're eating insect viruses, which just pass through you because they can't enter your cells. But
I'm sure you're also eating plant viruses.
Plant viruses, too. Do you like coleslaw, Amy?
No, I don't like mayonnaise. I don't like slime. There's no reason to slime.
With the Oxford study showing lack of sterilizing immunity, is it not true to say herd immunity is no longer achievable? Now, we talked about this last week on TWIV. So you don't need to have sterilizing immunity. You just have to reduce transmission. So that can be non-sterilizing. And we don't know if that's the case with these vaccines, whether they reduce transmission or not. That remains to be determined. But if you can reduce it, clearly population-level immunity depends on reducing transmission. What is the risk of ADE with this vaccine? Which one, the mRNA vaccine? Or any of them, I guess.
I don't think you have any data.
There's no data. However, previous SARS ADE was done in a mouse model, and there you have a lot of non-neutralizing antibodies, which don't neutralize infectivity but allow the virus to get into other cells by FC receptors of the antibody. Now, these vaccines are inducing good levels of neutralizing antibodies. So that reduces the possibility of ADE, but you can't rule it out. Sure.
Yeah, well, mouse models have caveats.
They do.
And so I don't know that I would totally extrapolate and use
not.
mouse model or use mouse model to suggest that to even answer that question. I mean, the closest you can get is the feline coronavirus vaccine that did have ADE, and Perlman will tell you it had ADE, but he doesn't expect there to be ADE here at all. He said that on Twitter.
Yeah, I know.
And he is the expert. So I'm going with Stan. I'm going with Stanley's opinion until proven wrong.
If you've had COVID, should you get a vaccine? Wouldn't immunity from prior infection be sufficient? No, you should still get it because we don't know what your level of immunity is. And so everyone should just get the vaccine anyway, and it will, boost your immunity. Does the mRNA vaccine need to get approved again if the sequence is changed to accommodate a variant, for example? Well, for the flu vaccines, they can change them on a yearly basis with very quick approval. They just have to do a very small trial. So I think I've heard 6 weeks they could have a new vaccine out.
Yeah, I think that's what the guy from the German man says when he was asked about whether or not they needed to change the Pfizer vaccine for the variant.
Yeah.
And he said, nope, I think it will be fine. But if it had to, it would take us about 6 weeks.
Can we expect a major push in getting the population vaccinated once Biden is president?
Yes. He's already come out many times to say that. And recently, either today or definitely yesterday, because he's all about Trump being a disaster and that this is just appalling. Yes. And he's reassessed some of his task force members to go through distribution and production and blah, blah, blah.
Okay, good question here. They're all good. Epidemiologically, could you say that mutation increases contagiousness if you do contact tracing and find on average people with one variant infect more people than with the other? That's one way you could do that. We talked about that today on Tweevo. And we don't have those numbers yet in the current outbreak. But since the virus has moved to new places or is in new places, then you could start doing that contact tracing like the person in Colorado and see, does she or whoever she's infect more people on average than another virus.
Turns out that the epidemiologists in Colorado are on the case.
Should we get them on Twiv?
Yeah, I'm telling you should write to Emily and have her on Twiv and have it on Friday. Yeah. Well, I don't know why he didn't respond. Maybe he's with the kids because she's on CNN or she was on CNN. All right, 12 more minutes, and then it's 9 o'clock. I have to play it out myself.
What do you think of the theory that the multiple mutations of the UK variant B1117 lineage arose in a hospitalized immunocompromised patient who harbored the virus for a long period of time? It's possible that might explain why you have so many changes in one virus. But in the South African situation, they also think it was a long-term infection that would generate viruses with many changes. They say it had to be, looking at the phylogenetic trees and the distances between isolates, it would have to be more than one immunocompromised patient, not just one person. But I think it's possible. Yeah.
Well, Adam Loring tweeted about his immunocompromised or the immunocompromised patient from polio who was shedding for like 28 years.
Yeah, we talked about the polio shedding today, yes. No, wife does not still work at Merck, left many years ago. Variant is also in California. All right. So we can do more tracing of subsequent infections.
Well, California's on like, especially Southern and Central California, they're like on total lockdown. It's like, whoa.
California. Information on blood type and susceptibility to COVID. The last I remember, the blood association did not turn out to be real. It was a locus on another chromosome, right, Amy?
I believe so.
But there's a paper by the Neanderthal paper explored that, because the Neanderthal locus is not the blood locus.
Right.
I got into an argument online with someone saying the mRNA platform is new, so we don't know if adverse effects can happen years from now. Any reason this vaccine would be different? What adverse effects would happen years from now, Amy?
I don't know.
mRNA is...
I don't think it's the mRNA per se. I think it's actually the lipid envelope.
Yeah.
That is the problem. Because people have PEG allergies and other allergies, and the composition of the lipids. The lipid envelope is not the same composition as your cell membrane. It's close, but it's not identical. So I don't know that I believe that the RNA itself is the problem. I think it's as I said, I think it's the lipid.
Okay.
And maybe you can develop autoimmune disease to the lipid and then have it, self-recognize, phosphoinositylserine or choline or something else. Maybe you do get that, but I don't know.
Yeah, no one can say there won't be any long-term effects due to the lipid. I think you have to, we just have to see. Okay, it's also in Nevada. Okay. All right, the dilemmas that may emerge in the intermediate phase when some people have the vaccine and others are still waiting. So I see that you still have to be masking and distancing, right? To make sure you're not infecting those individuals, right, until they get their vaccine.
Well, vaccination is not prevention of infection. It's prevention of severe disease.
Yeah.
And this actually came up in a conversation I had today about convalescent serum. So like we were talking about convalescent serum and whether or not it really works or not. And he was correcting me and he's correcting me. Well, whatever. Yell, correct at me. That I shouldn't go around and say convalescent serum doesn't work because the reality of it is we don't really know. And the measurement, so that I said something about like Shane's coming out and saying, when you treat with the monoclonals for Regeneron, it only goes down half a log. And he was correct to correct me. He's like, it's not about the lowering of viral load. It's about, did it prevent you from developing the next stage of disease? And he's right. We don't really know because we haven't done the appropriate tests or trials. And so he's doing it now in Brazil.
Since the AstraZeneca vaccine showed better efficacy with half dosing and the US EUA will be based on full dosing, would providers be allowed to vaccinate at the same reduced dosing as during trials? No, if the EUA is based on full dosing, that's the way you have to use it, is my understanding.
Yes, I think that until it's licensed, you don't have any leeway. But I'm not a lawyer. This isn't what I do.
Peggy says, dengue vaccine was pulled due to ADE, although it has 4 serotypes. Stanley can't predict long-term effects such as ADE. No, I think we were just saying that, what he's observed in his model. Because, you have nothing else to go by. You can't really predict, but you have to go by what you've observed. And Amy, of course, said that mice are not humans, so you have to take that into account. Do you think we'll ever determine the origin of the virus? I think so, but it will take time. We did that for SARS-1. Not we, but, investigators did. They were able to do wildlife sampling and eventually find viruses that were very similar and reconstruct it. And I think we should be able to do that as long as people can do wildlife sampling in China.
Well, at the rate we're burning bridges, probably not.
With China?
The whole world.
Well, we're changing an administration now, right? Won't that help?
Some damage you just don't forget the insults from.
Many people get the shot, think they are good to party on day one. Yeah, that's not good. I think you're not good to party even after the second shot. You have to still be careful until we know how much this cuts down transmission. Yeah, it's tough. It's tough.
Pandemic burnout.
I located to Idaho from New York. I feel homesick hearing your accents and seeing Amy's mannerisms. Oh, that's very nice.
It's
you
cute.
have New York mannerisms.
Yes, I've tried to leave New York. Does not work out well. They say you can take the girl out of New York, but you can never take the New York out of the girl. That is true.
So if no one really knows the long-term effects of the vaccines, how can you suggest that everyone should get them? Well, you have to make a decision. You have to do a risk benefit, right? You can get very sick from COVID or have a very small risk from the vaccine. That's how I look at it, because nothing is
Well,
risk-free, right?
somebody was 41 who didn't have any comorbidities and was thought to be in perfect health and died before he could be sworn in the House Senate in Louisiana. I'm not choosing death today. I have a lot of crap
Yeah.
I need to do.
No, so there will be people who do not get vaccinated because they're worried about it. But, until you're
Yeah.
years into the trials, you're not going to know this. I
Yes,
understand.
I know. I sat with somebody who tried to convince his colleague to get vaccinated. The colleague doesn't want to get vaccinated and was like, oh, I'll wait 2 months, blah, blah, blah. And my response was, you're going to listen to the guy nag you for 2 months? Are you a nut job?
Do you agree with CDC vaccination priority recommendations? Yeah, I'm third out of 4 on the list. I'm fine with that. I think you need to have healthcare providers, essential workers, and then the third group, me, 65 and older. I think that's okay. We have limited vaccine. A lot of people would rather have others up there, but I think it's okay. What do you think, Amy? Are you good with it? Amy's frozen.
I'm not frozen. I just don't want to. My opinion doesn't matter.
Okay. It's true. I shouldn't opine on it. You're right.
I didn't say you shouldn't opine on it. I just said I chose not to opine on it. I have.
Okay. Well, they wanted to know if we agreed with it.
Conflicting. They didn't ask unless they asked my opinion. I don't need to. I'm not going to judge it. It is what it is.
In a video, you stated the strain was just a mutation, which meant change, but now they're saying it's a new strain. So in the video, I said these isolates, this variant has a number of mutations, and whether they're responsible for increased transmission, we don't know. And it should not be called a new strain. So whoever's doing that is wrong.
What is the new biological phenotype that is attributed to it? The increased transmission is not a new biological phenotype. Did it infect a goat, a camel, a llama, the Martian next door? If it does all of those, then it can be considered a strain. But if it's just infecting us and it's more efficient at it, that's not a new biological property. It's a variant.
Many people think these vaccines are immunizing, so we have to explain it only prevents severe COVID. Yes, it has only been tested for preventing severe COVID and also mild COVID, but not infection and not transmission. But we'll learn in the next months whether it prevents transmission because studies are being done to address that. But in the meantime, you have to tell people that you have to chill until we know this. Oh, here's a good one. Isn't efficacy and effectiveness the same? No, it's pedantic, but there's a difference. Efficacy is what you determine in a vaccine trial. And the Pfizer mRNA vaccine has 94% efficacy. If you then license it and use it in the wild and you track how well it works, that's effectiveness. And the CDC site has that definition. It's not mine. So it's just so you can distinguish the two situations because they're different, right? A vaccine trial is highly controlled and life is not. Amy, life is not controlled. How about that for a saying?
Yeah, I'm a control freak. That's not working for me well. I have two more questions, and then I have to go play that myself.
WHO recently changed the concept of herd immunity from natural immunity to vaccine immunity. Do you know anything about this?
No, I was unaware.
Because herd immunity is typically something we achieve with vaccination, not natural infection. And that's because we can control the immunization, right?
But what the question is they're saying that herd immunity is the opposite. It's opposite of what you just said. That it was initially defined from natural immunity, and now it's being changed to accommodate vaccine immunity. And you said the opposite. No, so I don't know.
I've been teaching for 10 years. It's based on vaccine immunity. That's why.
Right, but that's not what he said. He said the WHO changed the concept of herd immunity from natural immunity to vaccine immunity. That's the opposite of what you're saying. So maybe the WHO just took your virology class.
All right, one more for Amy. If there's not enough vaccines for everyone, shouldn't people that already have had COVID go to the end of the line? No, that's not being done. Although it can be done on a state-by-state basis because every state is independent. But in general, we don't know what your level of immunity is after natural infection. So we would prefer to give you a vaccine to make sure it is good. And with that, I guess you're going to leave, Amy?
Yeah, I have to go play that myself.
Thank you for joining us.
Do tomorrow in the lab. I have to work on my grant papers.
All right, so thank you for joining us. We'll see you next week.
Yeah. Well, I'll see you next year. Happy New Year.
Yeah, I'll probably talk to you tomorrow, right?
Oh, really?
Sarcasm. The sarcasm.
No, it wasn't sarcasm. I was just surprised. I was just surprised. Oh, of course. Yeah. I'll talk to you tomorrow. Bye.
Bye. All right. Yeah, so here we have studies from convalescent plasma suggest ADE is unlikely. So, yes, that says, the convalescent plasmid are screened to make sure they have high levels of neutralizing antibodies in them. So when you have neutralizing antibodies that can bind the virus and block it from infecting, you're not going to have antibody-dependent enhancement. That happens just when you have a non-neutralizing antibody binding the virus. Then it gets taken into a cell and it can reproduce in the cell because the antibody is non-neutralizing, right? Okay. How similar is SARS-CoV-2 to 1 and MERS? Well, they're quite different. The homology is the identity is in the 80%. They have very different aspects of their reproduction and pathogenesis. Of course, SARS-1 is gone, and MERS continues to infect people. MERS does come from camels and infects people sporadically, about 2 cases a month, mainly on the Arabian Peninsula. And most of the camels in the region are infected at birth, and they get a little respiratory infection, then they recover, and then they can transmit it to the camel handlers, and people have camels as pets and so forth. So it's a zoonotic infection. It's always a spillover from camels to humans. It never transmits extensively among people. Every little outbreak is a spillover from camels to people. Which vaccine would be the most effective to lessen the severity of SARS-CoV-2 and variants? So far, they all should work against the variants. None of the variants have changes that would impact immunity by these vaccines. But as we said earlier, the mRNA vaccines can be remade very quickly. So if there is a change that emerges, we can make a new mRNA vaccine to address that. I should look this up myself, but I read that Pfizer has modified nucleosides. Yeah, it does, to improve stability and translation. And, the Pfizer and Moderna have studied the turnover. And with the modified nucleosides, it still turns over in a couple of days. And so it's a good trade-off. Stability and translation, of course, would result from that, yeah. A nurse got infected after the first dose. So, I don't see the clinical report, so I hate to comment on things like that. You need about 2 weeks to develop a good immunity. In the first dose, you're not 100% protected. You're about 50% protected. So that could have happened. Often people get immunized and then they immediately get infected because they don't have full immunity developed. And so that's what's going on. Yeah, so here we go. 22 days from first dose to full 70% efficacy from the data for AstraZeneca, then rising to 80% after the second dose. Wasn't the virus discovered in a cave in China in 2013? So the most closely related virus to SARS-CoV-2 was discovered in a bat in a cave in China in 2013, but it's not the ancestor. They both have a common ancestor. But that virus is too different from SARS-CoV-2. It has a few thousand differences in bases, so it can't be the direct ancestor. Something else had to infect people that was more closely related to SARS-CoV-2. And we have to find that. We may never find it because it may have been in a bat that no one has sampled yet. So that's what we have to find out. I'm looking for some more. I want to take a virology course taught by Amy. Yeah, you could do that. Well, she used to be a TA for my course, but she's not teaching anymore. Well, let me address this difference between influenza virus and COVID-19. They're both not coronaviruses. They're different families. You know, we put viruses into families, and SARS-CoV-2, MERS, SARS-1, they're all coronaviruses, a family of viruses put in there because of the genome. And influenza viruses are a different family entirely. They're both enveloped. They have spike glycoproteins, but very different, structurally very different. Biologically, the RNA is different. One is a minus strand. The influenza is a minus strand. One is a plus strand. So if you want to learn more, take my virology course online. It's on YouTube, free. 25 lectures, and we're starting a new series in January. We're going to have, a brand new refreshed course. So you can check that out. You believe people should be coerced into taking vaccines. I don't believe you can coerce people. You get into troubles. I think you have to make a good case for it. Now, companies can do what they wish, right? Private companies can say you have to be immunized to work here, and that's up to them. I don't really want to. I don't want to do that. I don't like coercing people. I try to educate people to get them to do things. It's not bad. We can get a lot of people immunized in this country. It's not perfect. I totally understand. Is it possible that asymptomatic people who get infected don't seroconvert? If they're infected, they're going to seroconvert most likely. I think that's unlikely that this would happen. And so a lot of people are asymptomatically infected, and serological studies have shown that, they have antibodies and they don't remember ever being sick, and that's how you do that, right? Vaccination communication limits the vaccine community to recipients regarding preventing disease. No, I agree. I think that it's very hard for many people to understand the difference between infection and disease, right? Most people equate infection with getting sick, and it's hard, and we try and do that on the podcasts, but we don't reach enough people. And so I think we have to do better. I told you, if you have to tell someone who doesn't particularly get it and talk to them, start in your family and your friends, your immediate circle, and so forth. Ooh, what if we can never reduce transmission? That would be horrible, but I think, well, first of all, then everyone or nearly everyone would eventually be immune, right? And then you would no longer have serious disease, but it might be difficult to get to that point. The common cold coronaviruses, which cause upper tract mild illness, most everyone in the planet is immune to them. We get reinfected every few years, but we don't get sick. So having high population immunity can prevent the serious outcomes, I think. I think that would be good. The authorities in the UK are extending the time between shots. It depends how long you extend it. If it's just, a matter of a week or two, that's not really an issue. You're still going to have, you will have a memory response no matter how long after the first shot you go, up to a certain point. Here we go. If you sold the idea of vaccines like cigarettes, yeah, right. I think that opportunity is gone, right? There are too many stories about vaccines. If you promise to top your gain of function experiments, I will help you find a decent and moral way of making science. I don't do gain of function experiments. I just do experiments, but I think they need to be done. Influenza vaccines depends on the particular year. They can impact transmission differently in different years, but they do prevent severe disease. They prevent death, and it's hard to quantify that. Oh, this is very interesting. We just talked about this today on Tweevo. Does COVID-19 experience recombination or reassortment during co-infection? So not reassortment because its genome is just one RNA, right? But it does do recombination, and it has a really high recombination rate, more than most viruses, because it makes a lot of these small mRNAs, and the process of making them encourages recombination. And so what might be, and Nels Eldy submitted this idea today on Tweevo. What could be happening is that when you isolate viruses with a lot of mutations in their genome, like the UK variant, it could be that a person was infected with multiple variants and they recombine to make the final one. So that is possible for sure, and that's going to be looked at. Is the furin cleavage site in SARS-CoV-2 any cause for concern? I don't think so in terms of variant changes affecting it. It's essential for reproduction of the virus, right? It has to be cleaved. The spike has to be cleaved there. And furins are ubiquitous proteases already. They're in many cell types, so it's not limiting the tropism at all. So I don't think it is. I think other changes that would affect antibody recognition, maybe receptor interaction or stability, would be more concerning. Yeah, so dengue vaccine was either pulled in some countries, or they said you can't use it unless you've already had an infection. But other candidates are in the pipeline, and so there'll be a different dengue vaccine soon. And now that Amy has a camera set up in the lab, can she demo how to do a plaque assay? Well, yeah, she's got the webcam I set up for her on the computer. But she does the plaque assays in the hood, which is on the other side of the lab, so I'd have to move it. I actually have a video of her doing plaque assays. If you go onto this YouTube channel, you can see a video about plaque assays, and she's the person doing the plaque assay. Antibody-dependent enhancement. It's when, let's use dengue as an example. There are 4 serotypes. You get infected with serotype 1, you make antibodies against it that are neutralizing. And then you get infected with serotype 2. You have a memory response to serotype 1. Those antibodies will bind serotype 2, but they won't neutralize. They won't block infection, but the antibodies allow the virus to get into, say, macrophages and replicate in them. And then that's a problem. I love Amy's wonderful crankiness. You have a good dynamic. I enjoy working with Amy. She's excellent, and I have been working with her for many years. She's a really good scientist. To take the strain off the hospitals, vaccinating the frail elderly in nursing homes. Yeah, well, that was one of the original goals, to do people in these institutional environments like nursing homes and so forth. Because, yes, they are highly at risk, as are and the people who work there, too, because they would bring virus in otherwise, right? So that's an issue as well. Thank you. I appreciate your comments. I try to be honest. I try to be rigorous and have high standards of science, and a lot of people don't like that. So, for example, with the current variants, some people say I'm wrong, and but I'm not really wrong. I don't think we've proven that these variants have higher transmissibility. So it bothers me when people are, I don't mind disagreeing scientifically, but when people make personal attacks, that's ridiculous, right? And I don't like that. So that makes me not sleep at night. Oh, how do neutralizing antibodies prevent disease? Well, they prevent infection, right? And then if you don't have infection, you're not going to get disease. And what they do, there are many ways multiple ways that antibodies can prevent infection of cells by viruses. The simplest way is they can bind to the spike and prevent it from attaching to the receptor, right? But there are other ways as well. The antibody could actually change the conformation of the spike, and then when it gets in the cell, it can't catalyze fusion of the virus and the cell membrane. And then there are other mechanisms intracellularly as well. So, yes, and then you could prevent cell-to-cell spread. The antibodies could bind on the outside of the cell. Now, you say, isn't neutralization mostly by preventing infection? Well, but preventing infection can be on the exterior or from within the cell. So it's all of that. And again, you take my course, you got a lecture there on that as well. Was the research on MERS and SARS-1 helped with developing vaccines? Well, so there are some vaccine candidates for MERS. There's an adenovirus, a Chadox-like MERS vaccine, which is in humans. And the SARS-1 candidate was made, but it didn't get past phase 1. So I think it helped a bit, but the mRNA vaccines, which are really pushing the envelope, didn't have anything to do with MERS and SARS, except, I guess, to say that we knew antibodies against the spike would be blocking infection. So I would say, yeah, that was important to learn about. How long would the effects of COVID-19 last after you've recovered? How long will the effects last? It could be years. It could be decades, long COVID, right? We simply don't know yet because it's early. It's less than a year, and many people are having months of persistence. I know people who have had COVID, they've recovered fully, and they can't catch their breath when they do very moderate exercise. That's just one example. There are neurological issues. There are many other problems as well. I learned the capsid shape follows the laws of crystallography. It's a great question. It's a bit much to answer here, but again, if you go on this YouTube channel, I have a lecture on virus structure, and it's an hour, and it'll tell you all about. So basically, there are a couple of different kinds of capsids. There are the ones that are based on geometry, like icosahedral capsids, and then there are ones based on envelopes that don't have that kind of symmetry. So that's all. And the symmetrical ones are based on very strict geometric principles, so quite interesting. YouTube.com/ProfVRR, which is where you are now if you're watching this live stream, right? Is there a pathogen for which the vaccine does not give sterilizing immunity, but for which we know that transmission it diminishes? So I would say measles is a good example of that. There are probably others as well, but measles is not sterilizing. Vaccine is not sterilizing. Yet it decreases transmission sufficiently so that we do get herd immunity. Now, you do need over 90% of people to be immune to prevent measles transmission, so it has a high bar because of the R0 is 15 to 20, right? One person can infect 15 to 20 other people. I would think that masks would stop most because the viruses are exhaled in droplets, and the droplets get held up in the mask material. It's not the virus particles that are coming out naked. They're coming in droplets, which are pretty big. How significant a mutation would be required to render current vaccines ineffective to a variant? So I would find it hard. So there are multiple epitopes on the spike. There are about 20 B and T cell epitopes on the spike protein. And so changing one should not completely abrogate immunity caused by, say an mRNA vaccine. But I would, with influenza, one amino acid change in a spike with multiple epitopes is enough to diminish immunity. So you don't completely lose protection, but you can still get infected and get mild disease. So that may be so one amino acid may be enough to allow some mild disease. But, in influenza from year to year, we see one amino acid change that could reduce the efficacy of vaccination. So that's the worst I think we could expect here. Now, as you know, from every 20 or 30 years, a brand new influenza emerges to which nobody has immunity. And then everyone gets infected and we have a pandemic. So, and that's what we have here effectively, a brand new virus, SARS-CoV-2. And so another one could come along in 20 years and do the same thing. But this one could vary from year to year, every few years, and simply reduce efficacy of the vaccine. How would one know if they got bad vaccine? Lots of things happen in transit. Yeah, this is I don't think you know. You have to really rely on it. And, you get your initial shot and you get a booster. And if they're from different batches, presumably at least one of them would be good. But I don't really know. People can assure you all they want, but really you don't know. But the process is working pretty well. And I have faith in it, let's say that. Is there any cytosol or liquid inside viral envelopes as a result of assembly, or are liquids repelled by hydrophobic proteins packed inside the capsid in space? That's a good question. I think there may be minimal amounts of aqueous environment inside the cell, right? The nucleic acids, the nucleic acids are sheathed, if they're negative stranded, they're sheathed in protein, which could counter a hydrophobic environment. But it's pretty tightly packed in there. So there's not I think there's not a lot of space for water, for example. Now, I do not know Tim Spector. Tim Spector. I don't believe Tom Solomon I know in the UK. I've had him on TWIV. I'd be happy to have any good scientist on my podcasts. Yeah, interesting. If the immune compromised can give rise to more mutations, should they go to the front of the vaccination line? Well, if they're immune compromised, they may not make an immune response, right? And so typically, depending on the immune deficiency, they're different ones. You give, let's say, people who don't make antibodies, A-gamma globulinemics, right? You give them monthly shots of pooled IgG to provide them with antibodies against a range of viruses because they can't make their own immune response. And so you can't just vaccinate them now because it won't, depending on an immunodeficiency, it won't work. Will we ever get back to normality? It's going to take time because we're not just talking about getting rid of the virus, right? Fixing social issues and the economy and political issues. It's just going to take time, but I think we will. I think we will, and I have no negative thoughts about that. I think we're going to be fine. But that's, of course, I can tell you that we're going to immunize and eventually control this pandemic, and the other stuff is kind of outside my expertise. Oh, was Hans, Amy was your TA in 2016. Very cool. So Amy, yeah. Okay, so Vincent, when you say you can't use epidemiological data to prove a biological fact. So right now, epidemiology is being used to say there's a more transmissible virus. In other words, looking how fast it spreads in an area, the reproductive index, right? Sequencing the genomes and watching them spread. So the theory is this is more... Now, there are many reasons to explain why you would get these transmission patterns, but one of them is that maybe the virus has become more transmissible. That's one of several explanations. And so I say, okay, then do some experiments to test that. For example, show that you have increased shedding from patients. That's a biological experiment. So the epidemiology makes inferences about the biology of the virus, and then you have to prove it. But I understand when we're in a public health emergency, as we are in now, we don't have the luxury of waiting a year or two for the experimental results. And I get it. So what do you tell people? Mask up, distance, blah, 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 the same things. What I object to is people saying this is a more transmissible variant. It has not been proven. And the newspapers are doing it. Some scientists are doing it. Others will agree with me that it's not been proven to be transmissible. So I want the data to do that. And that's all I'm saying. That's all I'm saying. Why do some vaccines need 2 shots and others just 1? Well, so far, You know, sometimes one is just not enough to give you the memory that you need. And the mRNA vaccines are like that. One shot is just not enough to get enough memory B cells and T cells going. You know, most vaccines that we use require multiple shots. The flu vaccine is an exception. But, you know, there are few COVID vaccines that are being tested that require only one. And, you know, all the ones, AstraZeneca, Pfizer, Moderna, they're all 2 shots. And some are in the pipeline with just one. We'll see how well they work. We'll see how they do. All right, we're 5 minutes away from letting you folks go. Do MERS-infected persons have immune response against SARS-CoV-2? Yeah, there are some cross-reactive responses. There's some conserved epitopes on the highly conserved proteins. What they do, whether those are protective or not, is not at all clear. Some people actually think that they're cross-reactive epitopes between the seasonal coronaviruses and SARS-CoV-2. There's one paper that we did on TWIV which suggests that. I don't fully buy it yet. I think we need more work to prove that. But one of the ideas is that kids who get infected often and early with seasonal coronaviruses have less infection with SARS-CoV-2. So that remains to be shown. Right. I keep hearing that cold weather is worse, but if that's the case, why is Southern California and Florida being hit so hard? That's a very good question because, you know, respiratory viruses tend to be seasonal in temperate climates, and they're more prevalent in the winter, right? And we think the conditions of cold and low humidity help that. But yes, of course, there are infections in warm climates, as you say, California and Florida. The tropics, they have seasonal influenza. So we don't know. We don't get it. We don't understand why transmission occurs. All we know is that in New York City in the summer, there's very little flu. There's very little rhinovirus. There are very few respiratory infections. And then in the winter, they come back big time. So in certain areas where you have a clear winter and summer, you can have that seasonality. But even in the tropics, you can have it as well. And we're totally not getting it. We don't get it. Yeah, OSHA has ruled that companies are allowed to make vaccination a requirement of employment. But of course, you have a choice of where to work, I guess, to a certain extent. Francis was on with this California governor today, called it a strain, then referred to it as a mutation. Well, I wouldn't expect non-scientists to get it right, okay? Only science aficionados, fine. But if scientists make the mistake, that's not right. Can SARS-CoV-2 recombine and reassort between lineages or with other? Yes, I think I answered this earlier, but you can get recombination with other SARS-CoV-2. And this is one of the problems we're worried about. If SARS-CoV-2 goes back into an animal and there are other coronas in there, it could recombine with them and come out a new virus in bats, for example. So it's a concern, and that's why we try to not allow this virus to get into animals, but it does anyway. On the origin, the sewers of Barcelona, I don't buy that at all. What they found was a mistake. It's an error because it wasn't circulating in people before November 2019. I am quite sure about that. I'm still wiping down every item of shopping before I store it in the fridge. Yeah, I used to do that early in the outbreak, but I think there's less and less evidence for transmission by these kind of touch routes. So now what I do is I bring everything home, put it away, and then I wash my hands. And that seems to be fine. How are hospitals testing for COVID versus influenza? They're PCR tests that distinguish the two. You can distinguish between flu and COVID for sure. There have been case reports about COVID-19 causing orchitis. I haven't seen those. I'd be surprised if it were directly a result of virus replication, right? Most likely that it's an inflammatory response. But we'd have to see the data, right? Recombination is when two viruses, so two different coronas are infecting the same cells. And then as the polymerase is copying one RNA, it moves to the other. So then the RNA that's made is got pieces of both in it. That's called recombination. If I understood you correctly, the vaccines are not designed to eliminate virus but reduce severity. Right. They're being tested for the ability to prevent disease. Whether they reduce infection and transmission is being studied now. In the next few months, studies are being set up to address that. Can vaccines eliminate virus? Some of them do. The HPV vaccine is quite good at preventing infection at all. All right, let's see. One more. Have there been any studies looking into what percentage of the population have been exposed to common cold coronas? Yes, there have been quite a few, and it's over 90% of the world's population has been exposed to the common cold coronaviruses. All right, folks, it's been a pleasure chatting with you tonight. If I didn't get to your questions, save them. I'll be back with Amy next year, the first Wednesday in the next year. So I hope you all have a safe, happy New Year, and be safe next year. And see you then. Take care. Bye-bye.